Good evening, ladies and gentlemen. Welcome to the APGS webinar series. Tonight, the topic of this webinar is the medical management in glaucoma. My name is Michael Cook from Seoul, Korea, and I will be moderating this evening's webinar along with Professor Catherine Lu from Taiwan. Now, just briefly, the objectives of APGS webinar is, as you know, to facilitate contact between glaucoma specialists in this region and to increase the opportunities for exchange of skills and knowledge in the field of glaucoma. And finally, to assist our ophthalmology colleagues to be up to date with all the advances in the glaucoma diagnosis and management. Now, in doing so, I think it's important to join the Asia Pacific Glaucoma Society. And I'm just going to briefly go over some of the excellent benefits that you will enjoy by joining the APGS. First, you will receive the registration discount to attend the APGC while your membership is active. And there's also access to APGS online education platforms with recordings of APGS web series and surgical videos. You also receive the quarterly newsletter, along with access to online communities to network and advance specific area of knowledge. You'll also receive free online Journal of Glaucoma, and you will also have right to vote and also electoral process in various APGS committees. So there are very much exciting, valuable professional networking opportunities by joining the APGS. And of course, you're also eligible for receiving awards and recognition by being a member of APGS. So please think about joining the APGS. Now, this slide shows some of the past APGS web series sessions, along with some videos on demand. So with that, I would like to briefly go over the structure of this evening's session. There are two sessions, by the way, in this medical management glaucoma symposium. And we'll have three presenters for each session, Professor Andrew Tatham, Professor Quaranta, Professor Norman Aquino, and the second session will be by Professor Kyung Song, Professor Kessara, and also lastly, Professor Makoto Aihara. The first session will be moderated by Professor Catherine Lu from Taiwan. So please, Professor Lu, so yours.
Okay, thank you, Michael. Now let's move on to the scientific part for today. It's my pleasure to introduce the first three speakers. The first one is Professor Andrew Tatham from University of Edinburgh, Scotland, who is going to address quality-based IOP reduction, a holistic approach in managing glaucoma. Then Professor Norman Aquino from University of the Philippines will talk about response rate, differentiating late versus non-responders. This is followed by Professor Luciano Quaranta from University of Pavia, Italy. He will speak on the impact of 24-hour IOP fluctuations on disease progression and pragmatic solutions. After their presentations, we'll have a Q&A with the three speakers. Please send through questions that you may have while viewing the presentation. Now, let's welcome Professor Andrew Tatham.
Thank you for the invitation to participate in this meeting. Over the next 10 minutes, I would like to look at how, if we look beyond intraocular pressure and take a more holistic approach to glaucoma, we might be able to achieve better outcomes for patients. Here are my disclosures. Though IOP is a well-established risk factor for glaucoma, many patients continue to progress despite pressure lowering. And evidence comes for this from randomized controlled trials. For example, in the UK glaucoma treatment study, 15% of patients continued to progress despite treatment. In the EMGT, which had a longer follow-up, the figure was higher at 45% of patients. We also have evidence of this from real-world data. So in the UK, a study of almost 4,000 patients predicted that about 15% would develop severe visual impairment or blindness during their remaining lifetime. And in Sweden, the figure was higher, at 1 in 6 patients blind in both eyes at their most recent consultation. So there's clearly some room for improvement. So when we're managing patients with glaucoma, what do we tend to focus on? Well, as ophthalmologists, we're very keen on taking measurements of intraocular pressure, structural measurements, and of course, visual fields. And these measurements have many advantages. They provide quantitative information and are very useful for risk profiling and setting treatment targets, but they're surrogates. They're usually not something of which the patient is directly aware. Patients are likely to be concerned about other things, and it's really important that we consider these factors in order to achieve the best real-world outcomes. So when we're trying to determine if a treatment is effective, we shouldn't just focus on intraocular pressure. We need to consider other factors such as treatment tolerability, adherence, and the effect of treatments on quality of life. So let's focus on intraocular pressure for a moment. There are several limitations to conventional methods of IOP assessment. IOP is affected by the biomechanical properties of the cornea. For example, in this study of almost 100,000 participants from the UK Biobank, there was a dramatic increase in the proportion of patients who self-reported glaucoma when the corneal hysteresis was less than 10. In a further study, the UK Glaucoma Treatment Study, IOP corrected for corneal hysteresis was a stronger predictor of subsequent visual field loss than IOP measured by Goldmann tonometry. So corneal hysteresis is important, and it's something that we should perhaps consider when setting target intraocular pressures. In this study, they looked at 179 eyes with IOP thought to be at target, and almost a quarter of these patients had visual field changes over time. And of those that had visual field progression, a high proportion had a low corneal hysteresis. So we should consider a more holistic approach to IOP and consider corneal hysteresis. Another limitation of IOP assessment is that pressure fluctuates, and we need multiple readings to establish therapeutic effect. In this study, they examined the reduction in intraocular pressure that would be necessary to have 95% certainty of a true reduction in intraocular pressure. If we only had one pressure measurement before treatment and one pressure measurement after treatment, we'd actually need a drop in pressure of about 7 millimeters of mercury for 95% certainty of a true reduction in pressure. If we had two measurements before and after treatment, we could reduce this to a drop of 4. But it shows that repeat measurements can be very, very useful. So what are the potential solutions to this problem? One is to maximize the accuracy of pressure measurements. And the best way of measuring pressure probably depends on the setting and the patient. In the UK, we're increasingly using telemedicine and virtual clinics, and we wanted to determine what might be a good way of checking pressure in the virtual clinics, where patients have their pressure measured by a technician and are not seen face-to-face with an ophthalmologist. And we found that the ocular response analyzer gave us a greater precision and measurement reproducibility compared to Goldmann in this particular setting. Another potential solution to maximize the information and the utility of IOP is to obtain more IOP measurements. And of course, in other chronic diseases such as diabetes, many measurements can be taken through self-monitoring, through home monitoring, and that's now possible in glaucoma using devices such as the iCare Home. We've conducted a series of studies using the iCare Home and found almost 75% of patients can measure their own IOP successfully, and the measurements had fairly good agreement with Goldmann tonometry. Acquiring a greater number of measurements might allow us to better determine risk of progression and the response to treatment. Home tonometry can typically be taught in less than 20 minutes. Normally, we conduct teaching face-to-face, but prompted by the pandemic, which hit the UK pretty badly, we've been posting home tonometry devices to patients, including a patient here in the Shetland Islands, which is closer to Norway than it is to where I am in Edinburgh. And we've been teaching patients how to use the device using video link, which has worked well. An alternative method of obtaining more IOP measurements is through the use of intraocular sensors. This is the iMate sensor, which is placed into the sulcus in combination with cataract surgery. And the patient then uses a handheld external reader, which provides on-demand pressure measurements. It also provides the device with a wireless power source. Last year, the results of the Argos 2 trial were published in the American Journal of Ophthalmology. And this looked at the 12-month performance of the device in 22 patients. Overall, there was good agreement with Goldman tonometry, but of course, the iMate has the advantage of measuring pressure directly, not influenced by the biomechanical effects of the cornea. This is an example of a patient who I implanted an iMate device in about a year ago. This patient had very high intraocular pressures, ranging between 25 and 35. We started them on acetazolamide here at point A. The pressure dropped, but they weren't able to tolerate it. So we inserted a Paul glaucoma implant here at time point B. There was a dramatic drop in pressure. Over the subsequent days, though, the pressure climbed. We removed the intraluminal proline stent suture. The pressure dropped, and there's been a sustained reduction in pressure. So this is quite an amazing device to be able to use. This patient had an incredible 700 measurements just during this 9 to 10 month period. And the patient had sustained engagement with pressure measuring. This shows the number of measurements per week over the last 12 months. So IOP is important, but there are limitations. And even with these developments in IOP monitoring, it remains a surrogate. For real-life efficacy, we need to focus on other key areas. As ophthalmologists, we love looking at eyes, but we need to remember our ears and listen to our patients, listen to the patient voice. The new European Glaucoma Society guidelines make some really good suggestions on questions we should be asking our patients, addressing some of those important domains for real-life efficacy. And these are questions that can help us better understand a patient's concerns and therefore align these concerns with treatment goals and help us adopt a holistic approach. We can also consider the use of patient-reported outcome measures, or PROMs, which often take the form of questionnaires. These can be general health PROMs, they can be vision-specific PROMs, and glaucoma-specific PROMs, and these now form a key outcome of clinical trials. A major factor affecting real-life outcomes is medication adherence, which is lower in glaucoma than many other chronic diseases. And poor adherence, of course, increases the risk of visual loss. The CGITS trial is one of the few studies to have captured longitudinal measures of both medication adherence and visual field. For participants who reported never missing a dose of medication, the average predicted visual field loss over 8 years was only 0.62 decibels, whereas those that missed 2/3 of doses had 3.6 times greater degree of visual field loss over that follow-up period. A holistic approach can improve adherence. This is a really good publication from the University of Michigan from August last year. They enrolled patients who had poor adherence, who were detected using electronic dose monitoring. And by using a holistic approach with a glaucoma coach, with education, they improved adherence in 95% of patients. Listening to the patient voice can also help us address the problem of poor treatment tolerability, which is a main cause of poor adherence. Poor tolerability can reduce quality of life in the short term due to reduced ability to perform everyday activities and the effects on social interactions, but also in the long term, as a patient who's not tolerating their treatment is less likely to take it and therefore at increased risk of disease progression. So in summary, real-life efficacy depends on us addressing at least these 4 factors. New methods of IOP monitoring might help us overcome some of the limitations of conventional tonometry, but IOP will always be a surrogate. And if we want the best real-life efficacy, we need to consider these 4 areas and listen to the patient voice. So I'd like to thank you very much for listening to me over the last 10 minutes.
It gives me great honor and pleasure to be with all of you today. It is now my turn to discuss a very important aspect of medical therapy in glaucoma, and that is assessing response to treatment. I have no financial disclosures to make for this particular talk. We are all very clear that in glaucoma, the goal of treatment is the preservation of vision and the visual field, and the maintenance of the patient's quality of life, and that the cornerstone of treatment is the lowering of intraocular pressure significantly and consistently. When we attempt to lower IOP through drops, there are very basic questions that we need to ask ourselves. What constitutes a positive response? When do we say that our choice of treatment is effective? How much IOP lowering should we aim for? And how long do we wait before we say that treatment is sufficient or not? These are very important clinical questions that we as clinicians need to answer. Hopefully, I will be able to provide some guidance in the next few minutes. Various glaucoma treatment guidelines, including the Asia-Pacific Glaucoma Society guidelines and the World Glaucoma Consensus guidelines, define a positive response to medical treatment as a drop in intraocular pressure of at least 20% from baseline. A negative response, on the other hand, is when there is a less than 10% drop. This simple slide, therefore, reminds us that 20% reduction or more should be our goal in treatment. The clinical guidelines are also unanimous in saying that it is the prostaglandin analog group that, as initial monotherapy, provides the best chance of achieving a positive response compared to other classes of topical glaucoma medications. Here we see a head-to-head comparison of the 4 prostaglandin analogs showing similar efficacy in lowering IOP from baseline up to the end of 6 months observation period in this particular study. Here we see that the differences in IOP lowering among these 4 are small and may not be clinically significant. Part of the reality that we should also accept is individual patient responses to medications may vary, and that the onset of a therapeutic response to medication may be different for each drug and for each patient. Likewise, we wonder how long the therapeutic response will be sustained for each patient. These questions add to the challenges that a clinician has to face. Remember, it is not safe to assume that medications, even those from the same class, will have a standard effect on all patients. Varying response rates are due to differences in the pharmacologic structure of the different drugs, differences in the affinity of the drug to the receptors, differences in corneal permeability, and differences in intraocular metabolism. There is a special category of patients who we can label as late responders. They are those that present with an initial poor response to therapy, but with time, eventually achieve an acceptable, adequate, and positive response as far as IOP lowering is concerned. Again, questions come into mind. How do you identify who is a late responder? How much time do we give before pronouncing a treatment to be as inadequate? And at what point do you decide the treatment plan needs to be changed? In a prospective open label study with normal tension glaucoma patients on tafloprost, we see that As the trial progressed, a subgroup of patients who initially showed inadequate reduction eventually achieved acceptable IOP reduction at the 12th week of treatment. These are the late responders. In the real world, there are no hard and fast rules that define how we identify them beforehand. We will only know if they are late responders if we observe them through time. Personally, if the severity of the glaucoma damage and the urgency of IOP control will allow me time to observe a patient's response a little longer, I would give a 4 to 6 weeks, maybe even 8 weeks, before I pass judgment, before I decide to modify my treatment plan. I would like to conclude this short talk by emphasizing that making a treatment decision in glaucoma is complex. It will entail choosing the most appropriate medication. It will involve assessing the initial response to treatment and determine if it is adequate or sufficient. It will entail continuous and meticulous monitoring through time and may involve adjusting or changing or modifying treatment plans according to any developments that may occur. Thank you very much.
Good morning. Today I will speak about 24-hour IOP fluctuation, impact to disease progression, and pragmatic solution. I am Luciano Quaranta, Director of the Eye Clinic of the University of Pavia, and these are my disclosures. We know that the IOP has a central role in determining glaucoma and its progression. This has been clearly demonstrated by several randomized clinical trials. As a matter of fact, the early manifest glaucoma trial, the advanced glaucoma intervention study, has clearly demonstrated that reducing intraocular pressure by the means of medical therapy, laser, or surgery is effective in reducing the rate of progression of glaucoma. Moreover, the collaborative initial glaucoma treatment study has demonstrated that either medical therapy and surgical therapy are both effective in reducing the rate of progression of glaucoma. Furthermore, the collaborative normal tension glaucoma study has demonstrated that when the intraocular pressure is lowered by 30% from the baseline, it's possible to reduce, also in this particular form of glaucoma, the rate of progression of visual field. More recently, the UK GTS, the United Kingdom Glaucoma Treatment Study, has demonstrated that patients treated with latanoprost compared with patients treated with placebo has a lower rate of progression when compared after 24 months. And this is extremely important because we have a modern demonstration with modern drug that is a prostaglandin analog that reducing the intraocular pressure is beneficial to reduce the rate of progression of the disease. But when we speak about intraocular pressure, we have to know how to measure intraocular pressure and how many measurements we have to perform in our clinical practice. So we can choose to have a single measurement, a diurnal phasing, or a 24-hour IOP phasing. But before entering in the gamut of all the terminology of intraocular pressure parameters, it's important to know that there are different parameters: long-term fluctuation, mean intraocular pressure, peak intraocular pressure, and short-term fluctuation. When we have to perform a diurnal phasing, we estimate that in an almost busy glaucoma clinic, we perform a diurnal phasing that in no more than 10-15% of all the patients visited during a year. So when we have to choose to perform a diurnal phasing, when we have progression of visual field in spite of a normal intraocular pressure, in this case 13 millimeters of mercury, a good concordance between fields and disc, and in this case is indicated to perform an IOP phasing. But when we have progression in spite of an elevated intraocular pressure with a good concordance between fields and disc, we have just to change therapy. In this last case, for example, when we have a normal intraocular pressure, progression of the fields, but no concordance between fields and disc with no match, we have to dedicate our examination for this kind of patient. So we have just decided when to perform an intraocular pressure phasing in our patient. But how to perform an intraocular pressure phasing, a diurnal intraocular pressure phasing. According to European Glaucoma Society and World Glaucoma Association, we have to perform 4 IOP readings in sitting position by the means of Goldmann applanation tonometer, and 1 IOP reading in supine position early in the morning. We have to perform this kind of measurement or with Perkins tonometer or just with Goldmann applanation tonometer, passing the patient from supine to sitting position and just after that measuring the pressure. So from this kind of measurement, we can obtain mean intraocular pressure, fluctuation of intraocular pressure, and see if target pressure is reached throughout the diurnal phasing. And this is a really important clinical parameter. Let's see what's happened about fluctuations. If we see this clinical case, there is almost stability of the field as determined by GPA and just a fluctuation of 1 millimeter of mercury throughout a 5 years follow-up. We can see that in this case, even the pressure is quite well controlled and there is no progression of the disease. As a matter of fact, long-term fluctuation is not very high. But if we see this kind of patient with a mean intraocular pressure even lower than the case before, but with greater fluctuation of intraocular pressure in the long term, you can see that there is a progression of visual field throughout the follow-up. So, as a clinician, it's also important to measure long-term fluctuation because long-term fluctuation has been demonstrated to be an independent risk factor for the progression of the disease. And it's quite easy to be evaluated by the clinician, just plotting the values of intraocular pressure against time and to see the mean and the fluctuation over time. When we speak about circadian rhythm of intraocular pressure, of 24-hour intraocular pressure, the modification of intraocular pressure are essentially due between a balance between production and outflow. And these are mainly due to postural changes, geographical influences, autoregulatory mechanisms, disease and drugs, and aging. We know from the literature that aqueous humor production is decreased at night, almost 50% due to a prevalence of beta-adrenergic tone during the nighttime, and outflow facility is probably decreased at night, both pathways, both the trabecular and the uveoscleral pathway. So let's see what's happened throughout the 24-hour in glaucoma patients. This is a classical study by John Liu that has been demonstrated that intraocular pressure increased during the nighttime in supine position, both in normal and in early glaucomatous patients. And there is an acrophase of intraocular pressure in glaucomatous patients early in the morning. And it is important to dedicate a particular covering, even with drugs, of this period of time during the nighttime. So increase of intraocular pressure during the nighttime is a physiological mechanism due to reduced outflow of aqueous humor, due to also an increase of episcleral venous pressure. And so we have to consider, if we want to reach a target pressure throughout the 24 hours, to try to flatten the intraocular pressure curve throughout the 24 hours. But we know from a clinical point of view that it's almost impossible and impractical for the clinician to perform a 24-hour measurement of intraocular pressure. So we need a surrogate that is able to give us an idea what is going to happen during the nighttime in supine position. Fogagnolo and co-workers has demonstrated that a single measurement of intraocular pressure in supine position during the daytime is able to predict which is the behavior of intraocular pressure during the nighttime. And this is extremely important. In a wider cohort of patients, we have not confirmed this hypothesis. As a matter of fact, the higher intraocular pressure during the nighttime does not consistently predict the highest nighttime sitting or supine IOP value. So in case of progression of the disease, we really don't have a precise surrogate of intraocular pressure during the nighttime, also with the supine position test. Also, even if, in my opinion, is a nice idea to have just a single measurement of intraocular pressure in the daytime in supine position to try to understand which is the balance between sitting and supine and decide if, in case of progression of the disease, to furthermore decrease intraocular pressure. Another escamotage that is possible to use is the one proposed by Tony Realini, that has seen that it's possible to build a surrogate daytime IOP phasing, just plotting the intraocular pressure obtained over time, so different measurements over time by the clinician, in a single daytime curve. And there is a good concordance between these measurements when compared with a daytime intraocular pressure phasing. So this kind of strategy can be helpful for the clinician in order to understand ever fluctuation, ever short long-term fluctuation, but also short-term fluctuation, the fluctuation that happens during the daytime. So IOP is not constant over time. IOP varies in the long term and in the short term. And IOP can be categorized by mean, peak, or fluctuation. And let's see what's happened about these variables. The Advanced Glaucoma Intervention Study has demonstrated that when intraocular pressure is low, constantly low, over the long-term follow-up, this kind of patients tend to progress less than the patients that try to fluctuate more. Two parameters are very important: fluctuations over the long term and mean intraocular pressure. So the message from the AGS is that the pressure has to be low and constantly low over time in order to avoid or to slow down the progression of the disease. In a retrospective study evaluating 24-hour intraocular pressure over 5-year follow-up, we have demonstrated that intraocular pressure lower than, as regards the mean diurnal intraocular pressure, lower than 18 millimeter of mercury, we have almost 75% of patients stable over a 5-year follow-up. When considering 24-hour mean intraocular pressure, we have stability of fields and progression of the disease in 75% of patients when intraocular pressure is lower than 16 millimeter of mercury. Same results were obtained by diurnal peak IOP and 24-hour peak IOP. As a matter of fact, when 18 patients were lower than for intraocular pressure 18 millimeter of mercury, both for diurnal and 24-hour IOP, we had a 75% of stability and no progression of the disease. So 18 seems to be the magic number obtained both from the ages and from our study. And this is true even in the long term, but also in the short term fluctuation of intraocular pressure. So when we perform a 24-hour intraocular pressure measurement, even considering mean and peak IOP, we have to try to reach this kind of target pressure. There is a clinical utility of 24-hour IOP monitoring. Apart from the unpracticability of 24-hour monitoring, this nice work of Barkana, the group of Robert Rich, has demonstrated that there are some patients in which intraocular pressure try to peak outside the office hour. And so, in a certain percentage of patients, it's possible to change therapy, to try laser, or go to surgery if this kind of pressure is not reached. So, in some selected patients, can be helpful to monitoring intraocular pressure throughout the 24-hour in order to decide the best therapeutical strategy for each single patient. My opinion is that it's not possible to categorize a patient as a normal tension glaucoma if we don't perform a 24-hour IOP phasing. Even if I understand that it is almost very difficult to perform a 24-hour IOP phasing, especially associated with blood pressure monitoring, but it's my opinion that especially for this kind of patient, it's really important to understand if there are any peak of intraocular pressure outside the office hour in order to understand if there is a prevalence of IOP risk factor or independent risk factor like vascular risk factor, low blood pressure in this kind of patient in order to set the most appropriate target IOP. In one of our work on the 24-hour effect of drugs in glaucoma patients, we have clearly demonstrated that, for example, timolol is most effective during the daytime, less effective during the nighttime. Dorzolamide, a carbonic anhydrase inhibitor, is more effective during the nighttime and less effective during the daytime. Brimonidine has almost a neutral effect, is almost similar like dorzolamide during the daytime and like timolol during the nighttime. The most effective drug in reducing the 24-hour intraocular pressure was latanoprost, but was able to reduce almost uniformly the intraocular pressure throughout the 24 hours. But combination between these drugs are mostly useful in flattening the IOP curve throughout the 24 hours. This is another work that we have performed in which we have shown that timolol-dorzolamide was more effective with brimonidine-timolol fixed combination when comparing the two drugs in a 24-hour curve. And so from the graph, you can see that there is a significant difference between the two drugs throughout the 24 hours. A particular effect of an intraocular pressure was obtained by using tafloprost, that is a prostaglandin, the last generation prostaglandin analog, but intraocular pressure was almost similar to latanoprost during the daytime, with a prevalence of IOP reduction of latanoprost during the daytime, but was more effective than latanoprost during the nighttime. And this is a characteristic of tafloprost also in our study that we have performed. Last, if we want to perform a very effective IOP reducing therapy, we have to try to add to prostaglandin analog like tafloprost with one of the most effective combination of drugs, that is dorzolamide timolol fixed combination. From this slide, you can see that in patients low responder to latanoprost, when using tauproprost, a significant decrease of intraocular pressure. But you can see from this graph, which was the reduction of intraocular pressure by use this kind of therapeutic strategy. So this kind of strategy, especially if preservative-free, that can be helpful in preserving ocular surface in our glaucoma patient, can be considered a maximal tolerated medical therapy for glaucoma patients. In conclusion, we can state that a 24-hour IOP pattern is not completely elucidated both in healthy subjects and glaucoma patients. Prostaglandin analogs have a strong 24-hour IOP effect and are able to reduce the spike of IOP due to postural changes. And finally, the knowledge of 24-hour IOP behavior of glaucoma medication could help in tailoring the most appropriate therapeutic approach for each patient. Thanks for your attention.
Now it comes to the time for Q&A. There are so many questions, I can choose some of them. One asked Dr. Andrew, do you suggest that IOP checked by technician is better than the doctor? This is asked by Dr. Shah.
I think the study that I was referring to was really comparing different devices and the accuracy of the devices in different hands. So, what we looked at was the ocular response analyzer performed by technicians. And I think one of the advantages of that is that if the clinician's not performing pressure measurement themselves, and you're looking at the pressure at a later date, in Goldman, for instance, there's no sort of index of accuracy, whereas some other devices can give you a measure of the accuracy of the IOP measurement. So I think that was really the key of that study, that different devices can have different value and different questions.
Here's another question. Thank you for lectures. What method of tonometry do you use nowadays in pandemic period? I think this is also a question for Dr. Tatham and Dr. Quaranta.
Yeah, we switched. My preferred method when I'm seeing a patient face-to-face is Goldman tonometry still, though there are some limitations. I do like to have knowledge of the hysteresis as well, but I use Goldman. But when the pandemic started a year ago, we really wanted to reduce the face-to-face time we were spending with patients. So we switched to rebound tonometry. And also within our virtual clinics, our telemedicine type clinics, we usually use the ocular response analyzer, which is an air puff tonometer. And initially there were some concerns about sort of droplet spread using air puff tonometry, but so we switched again to rebound tonometry. But I think there's increasing evidence that rebound tonometry is
another question is that what is the significance of measuring 24 hours monitoring IOP? Will Professor Quaranta would like to answer this question? Or any other?
Was that question to me? Sorry, was that question?
I think the audience just want to know the significance and how many patients do you measure 24-hour IOP, and what kind of patient do you measure the 24-hour IOP? I think that's the purpose of the question.
Yes. Well, I think that the number of patients in which we measure 24-hour IOP were traditionally just conducted for the diurnal pressure curves, which really just a daytime measurement. We traditionally measure a 24-hour IOP curve to admit the patient into the hospital. But I think in many settings it's really isn't feasible. But some of the exciting developments that I showed in home telemetry, I think really do open up the possibility of having a greater number of IOP measurements in patients throughout all measurements, all hours of the day, and also for a prolonged period of time. But yes, a good question. Which are the best patients to use home tonometry or use 24-hour IOP monitoring? And I think that there is a lack of evidence at the moment because these technologies are quite new. Personally, I find it quite useful when patients seem to be progressing with a fairly low intraocular pressure, trying to determine whether they might be having IOP spikes outside of office hours. But, yeah, I think there's a lot more work needs to be done to determine which patients might benefit from having the IOP movement.
Okay, thank you. Here's another question. What is your first choice in terms of fixed combination drugs? First choice of fixed combination drug. Any speaker can answer this question. What is the preferred fixed combination drug?
Catherine, maybe I can give my view on that. As I said earlier, it is a recognized fact that the prostaglandin analog group is the one that can give us the IOP lowering that we want and we would want to hope for. However, there are cases, there are patients who will not respond as well as we want them to with just one single prostaglandin. So my next step is to combine it with usually a beta blocker in a fixed combination modality. Again, to encourage adherence, to encourage persistence by having to deal with just one bottle. And if I have the option of having that fixed combination drug in a preservative-free form, I think that is going to bring added value as far as minimizing the adverse side effects that we can have.
Okay, thank you. Anyone want to add some information? Here comes another question. What tonometry do you recommend for post-LASIK patient? We know that this kind of patient has flattened and thin central cornea. And so in your practice, usually what type of tonometry do you perform for this kind of patients? Norman?
Well, ideally, you will have to employ the use of a tonometer that would take into consideration the corneal characteristics, the corneal biomechanics, all right? But again, in the real world, and let me just say that in my own practice, I do not have access to such. And I just base my IOP readings on a well-calibrated Goldman tonometer, taking into consideration how thin or how thick the cornea has become after the refractive procedure. And of course, I will have to just not take the numbers, but also have to take into consideration what is happening to the disc, or if there are any changes, because as we all know, the numerical value of IOP after a refractive procedure is not that reliable.
Thank you. Andrew, do you want to say something about IOP measurement for LASIK patient?
I completely agree with Norman's points, because I think something that all three of us have emphasized really is that IOP is a surrogate measure, and the methods of measuring IOP all have limitations due to the biomechanics, due to IOP fluctuations. And so the patient, really the key thing we want to know is the patient progressing. And if they are not progressing, we know that we've probably got the IOP at a good level. And in some patients, IOP.
Okay, and we'll still have some more time. And someone asked that what is the target pressure for patients with normal-tension glaucoma? A very hard question to answer. So usually for patients with normal tension, to start with, what is your target pressure? Is 30% reduction from the baseline or anything else? Maybe Andrew, would you like to answer?
Well, I think target pressure is a difficult one, isn't it? Because there's different ways that you can propose target pressure, based on reduction, based on an absolute number. I think it depends. It depends on the individual patient. So if that person has a short life expectancy, you might expect slightly higher pressure. And the person would probably want to line pressure was very low to start with. So I think target pressure is a very individualized thing, and it also can change. You might set a target pressure and then find that person progressing, and refine it, and lower our target pressure. Or in some cases, we overtreat people who can actually raise our target pressure. So target pressure is quite a complex thing to address.
Okay. Another question here is that is there a difference between slit lamp mounted Goldman perimetry and Perkins tonometer? Question asked by Korea. There any difference in the measurement between slit lamp mounted Goldman tonometry and Perkins?
I personally have no knowledge about any investigation to compare the two, but all I know is that they work by the same principle. It is considered indentation type of tonometry. But again, if there is some technical issues related to one being slit lamp mounted and the other being, handheld, I really don't know. I really don't know.
Yeah, but personally, I admire anyone who can take accurate measurements with the handheld Perkins.
I agree, Andrew. I agree.
Very difficult to do. But I think some people can get accurate measurements. But I think that's one of the key things. The accuracy of any device depends on the user and the operator, how well trained, familiar they are. I mean, there's a meta-analysis a few years ago looking at various different tonometers. Found that on average, all of them have a reading about 3 mercury, so which again goes back to the target IOP. That 3 millimeters of mercury can be very different. Somebody has normal pressure glaucoma. So I think that's why taking the repeated measurement is quite helpful.
Okay, I think people are really curious about what is the best glaucoma medication for eyes who underwent PKP and having secondary glaucoma. Do you think we should have different approach, start with different kinds of glaucoma medication in patients who had undergone PKP, or we just treat it as usual patients?
First of all, I would suggest that a patient that develops glaucoma after a corneal transplant has to be investigated as far as what is the mechanism of the glaucoma. There would be an angle closure type of etiology to a post-PK patient. There would be an open angle type of etiology in a post-PK patient. Once that is determined, then it is going to be relatively easier for us to choose whether we go with an aqueous suppressant, whether we go with an outflow drug, So to me, that is the first step, particularly to the beginner, to the students, that they first establish what is causing the glaucoma for them to plan as to what is best.
Yes, it's very true, because you must understand what's the underlying mechanism for elevation of intraocular pressure, and then you can decide what is the next step to do. So there are still some more questions unanswered. but unfortunately, because of the time limit, we have to move on to the next session. Back to Michael.
Good evening again, ladies and gentlemen. Let's start with the second session here. We have 3 presenters for our second session of the medical management of glaucoma. Our first presenter is Professor Kessara Pathanapitoon, who is from the Faculty of Medicine at Chiang Mai University, Thailand. And she will speak to us about the unmet needs in glaucoma management today, focusing on patient adherence. And then next speaker will be Professor Kyung Song from the Assam Medical Center, University of Ulsan College of Medicine, Seoul, Korea. And she will speak to us about the safety considerations in managing glaucoma, particularly speaking on the Prostaglandin associated Peri-Orbitopathy syndrome known as PAPS. And the last presenter of this evening's webinar is Professor Makoto Aihara, who is the professor of Tokyo Medical School and president of Japan Glaucoma Society, Japan. And he will share with us the clinical solutions to address PAPS. So let's start with Professor Kessara, please.
Hello, everyone. Thank you, APGS, for inviting me to speak in this meeting. I have no financial to disclose. The outline of my talk will be what is adherence, why it's important, and how can we improve it. The commonly used term compliance has been increasingly replaced by the term adherence, both defined as the cooperation of the patient with the recommendation given by the doctors. Adherence is typically used to describe how well a patient takes the prescribed medication, while persistent assess whether or not the patient stops taking the medication. White-coat adherence means the patient increased adherence preceding a scheduled office visit, typically 2 or 3 days before visit, making it difficult to assess either adherence or long-term intraocular pressure level. Why adherence is so important? Glaucoma is one of the chronic conditions that require long-term use of medication. Patient compliance is a well-known issue in the treatment of the chronic disease. A study comparing adherence and persistence across 6 chronic medication classes found that the adherence to the prostaglandin eye drop, which is our first-line treatment, was lower or almost lowest to the other therapy. A recent report from the collaborative initial glaucoma treatment study showed that There was a dose-response relationship between the extent of the medication adherence and the visual field loss. As shown in this graph that the patient who reported more missing dose of medication tend to have more visual field loss. This is a clear and significant link between the poor adherence and the visual loss, and emphasize that helping the patient improving their glaucoma medication adherence is critically needed. As glaucoma patients have no symptom or associated gradually change in the visual function, or treatment have no tangible improvement, patients may not fully understand what eye pressure is and what its effect, why we monitor visual field loss and change intraocular pressure, but these measures may not be meaningful to the patient and lead to insufficient motivation to adhere to the treatment regimen. The rate of the glaucoma adherence among the glaucoma treatment with the eye drops, what is how much in your clinical practice? And how about the main barrier to the adherence? Is it because of the administration difficulty, intolerant issue, forgetfulness, economic issue, or patient believe that they have no symptom? Why patient miss the drop? Well, there are several factors that affect the non-adherence. First is the physician who lack of communication with the patient, or patient themselves who lack of concern about their disease, the ability to apply the drop correctly, and many other factors such as their other commodity, lifestyle, educational, socioeconomic. For the medication, safety and the tolerability and complexity of the treatment, cosmetic as well as the cost, all of these factors could affect the patient adherence. And the last is the provider or the policy. This could affect the reimbursements and the expense of the medication. How can we improve it? Identifying non-adherence are quite challenging. Several methods have been used to identify non-adherence, including self-reported, visual report, direct observation, electronic medication monitor. In clinical practice, we may simply ask the patient with open-ended question. For example, have you forgotten to use your eye drop during the last week? If yes, how many times? Sometimes asking the patient to demonstrate their drop installation technique is also useful, as shown in this photo that the younger patient can apply the drop properly than the senior one. Several studies show that there was significant improvement in adherence after educational intervention. However, the study used very different intervention. It's more difficult to determine which specific aspect of each educational intervention had the most impact on the adherence. Recent study enrolled patients with poor adherence using dose monitor, receive 7-month support, educate, and empower coaching program, include automated medication reminder, counseling session with coach, and 5 telephone phone call. Found that 95% of the patients have improved in adherence. In clinical practice, I think setting the alarm and messages seems to be chief an easy way to remind the patient who forget to take their daily medication. As you may already know that poor treatment tolerability is the main cause of poor adherence in glaucoma. Patients with glaucoma tend to have higher prevalence of ocular surface disease, such as MGD, tear film instability, toxic keratitis, contact dermatitis, and the allergic conjunctivitis. Preservatives as well as the ingredients are responsible for this side effect. The toxic action of preservative to the ocular surface have been demonstrated in vitro, in vivo, and in the clinical practice. And long-term toxicity of the preservative could also inhibit intraocular pressure control due to its effect on the trabecular network and filtration surgical failure. Another ocular surface problem from the prostaglandin treatment is the prostaglandin-associated Peri-Orbitopathy. This can be seen with different in frequency and severity among different types of the prostaglandin and can cause cosmetic problem, especially in the eye with the unilateral treatment. It can be reversed after stopping prostaglandin as shown in the figure. Some PTA had more severity, and luckily enough that it still can be reversed, but this takes about 1 year. Choosing treatment with a greater tolerability may help patients adhere to the therapy. The clinical evidence demonstrated that preservative-free eye drop can lessen the ocular surface problem, resulting in a better tolerability and adherence. The fixed combination have been developed to reduce the exposure to the preservative and more safety with less complexity. The new PGA E2 have been developed to reduce PAPS and may not lead to improvement in adherence from the better cosmetic. What are the unmet needs in treatment adherence? I would say that first is the physician who are so busy and have no time to communicate with their patient. And currently, several methods that we use to improve adherence are largely still rely on the patient. The last is unfortunately that the less toxic medication may not be available to our patients through our health insurance plan and may cost more than their individual component. The early intervention glaucoma treatment, including selective laser trabeculoplasty, minimal invasive glaucoma surgery in open angle glaucoma, or clear lens extraction in angle closure, may be considered or offered to the patient, especially those who tend to be poor adherence. The novel drug delivery system, including bimodal ring, frontal pack, or travoprost implant, or injectable product, may offer a sustained intraocular pressure lowering without the need for self-administration. However, more research is needed when these novel therapies are introduced into clinical practice to assess their effect on the patient adherence. In summary, non-adherence is multifactorial and cannot be addressed by a single strategy. Currently, most studies on adherence were from the West. The difference between the healthcare system and socioeconomic aspect might affect the applicability of some factor to others. The research may lead to the recommendation or guideline, but might not be applicable in the real world practice. Anyway, the factor that we can help or modify are increasing communication with our patient and choosing medication with less toxicity and less complex, or considering intervention glaucoma treatment in those who tend to be poor adherence while we are waiting for a better way to deliver the drug. Thank you for listening.
Hi everyone, I'm Kyung. Today I'll be speaking about the PAPS, which we usually encounter when managing our glaucoma patient. IOP lowering is the only proven effective therapy for glaucoma patient, which is proven in many big studies. Especially, CNT study confirmed that treated group, which achieved more than 30% of IOP reduction, showed less probability of glaucoma disproration. Hence, IOP lowering medication is the most important point in glaucoma patient care. However, problem is that not all glaucoma patients are compliant to the medication. The reports show that glaucoma patients are only taking between 30 to 70% of doses, and 1/3 of the patients discontinue therapy in the first year. Considering that we are living in aging society, mean treatment period will be also increased significantly. So continuous good compliance to glaucoma medication is of paramount importance for glaucoma patient care. The research outcome also revealed that patients with poor adherence were likely to progress than who were not. Then why patients stop medication? The common reasons were forgetfulness, difficulty with the drug administration, and difficulty with the medication schedule. In that perspective, PGAs are very good drug, which can obtain strong IOP reduction with once-a-day use. Currently, 4 kinds of PGAs are available, and those are also included in fixed combinations. PGA becomes the most frequently used medication, and if we include fixed combination drugs, majority of glaucoma medications are including PGA components. Although PGAs do not cause serious adverse side effects, but they also have problems such as ocular inflammation, systemic macular edema, herpetic keratitis, and so on. The other issue is related to periocular changes, which include flattening of the lower eyelid bag, upper eyelid ptosis, involutional dermatocalasia, orbital fat atrophy, tight orbit, and deepening of the upper eyelid sulcus. More than 60% of the patients experience so-called PAPS, prostaglandin-associated Peri-Orbitopathy syndrome, after just 6 months use of topical treatment, sometimes as early as within a month of PGA initiation. This survey shows that presence of adverse drug reactions by looking at the photographs was more commonly noticed by the patient, which may reduce adherence to the medication. PAPS were 3 times frequently observed in patients with more than 60 years old. Such Peri-Orbitopathy causes not only cosmetic problems, but also affect the clinical care itself. For instance, deepening of eyelid sulcus dukes makes IOP measurement difficult, and cumulative probability of IOP elevation was higher in eyes with dukes after trabeculectomy. So the dukes affected trabeculectomy outcomes. Then how to treat PAPS? American Academy of Ophthalmology recommends to discontinue the causative therapy, and this often resulted in partial to complete reversal of PAPS characteristics as early as 4 to 6 weeks. However, cessation of treatment may lead to increased intraocular pressure, worsening of glaucoma itself, and the patient will need other topical or systemic medications, for instance, acetazolamide. So the PGA therapy switching to other PGA itself is unlikely to be a long-term solution for PAPS. The long-term mechanism of IOP reduction in PGA was reported to be included by extracellular matrix remodeling and subsequently widening of the intermuscular space in ciliary muscles, which led to increase of uvascular outflow. However, such remodeling of ECM badly affects the eyelid tissue, causing eyelid malformation and ptosis. Further, PGA binds to FB receptor, and which activates orbital periadipocytes, inhibit adipogenesis, reduce orbital fat. FB receptor binding also promotes cell growth, inducing a growth phase in resting follicles and hypertrophic follicles, which increase the length and thickness of eyelashes, make additional lash rows. Recently developed EP2 agonist binds to EP2 receptor, which increases cyclic AMP, and this drug rarely induces PAPS. EP2 receptor is abundant in trabecular meshwork, so EP2 agonists omit and affect isopropyl acts on trabecular flow and increase outflow facility in conventional route, while PGA-FP receptor agonist acts on uvascular flow. OMDI substantially improved PAPS when switched from conventional PGA after 6 months of OMDI, and some eyes showed improvement in dukes, flap, and skin pigmentation. What about IOP lowering effect of OMDI? Compared with the latanoprost, OMDI showed non-inferiority at 4 weeks, showing about mean 6 millimeter mercury IOP reduction. Slightly higher percentage of conjunctival hyperemia was reported in OMDI, but there was no serious adverse effect. IOP was substantially lowered in low pressure group as well as in the high pressure group. When combined with the timolol use, more than 3 millimeter mercury IOP reduction was achieved in high tension group. IOP reduction was maintained at all time points in the use of OMDI. Fuji study was conducted to explore the efficacy of OMDI in patients whose IOP control was not satisfactory with the use of latanoprost. Conversion to OMDI reduced IOP about 3 millimeter mercury, which showed OMDI can be a choice in eyes with PGA non-responders. So in summary, various spectrum of PAPS has been reported in the use of prostaglandin analogs. These adverse effects are mainly derived from F receptor binding. PAPS may induce poor adherence to medication and glaucoma care. PAPS lowers the outcome of trabeculectomy as well as causes cosmetic problems. Simple discontinuation of PGA improved PAPS in some patients, but if the patient needs more IOP reduction, novel EP2 agonist can be an option. Thank you very much for your attention.
Hello, everyone. So I will talk about clinical solutions to address PAPS. This is my COI. At first, we need to understand the mechanism of PAPS. I want to show some basic data. Originally, it has been reported FP receptor stimulation by PGF-alpha inhibits adipocyte differentiation in vitro. As regarding to PAPS, so histological analysis indicate orbital fat in patients treated by PG analogs was reduced in volume, and the density of adipocyte increased in deepening of upper eyelid dues. We verified prostaglandin analogs inhibit adipogenesis in 3T3L1 cells in vitro. So this is one of the study showing histological changes of dues. As you can see in the figure, the right is the treated eyes and the left is the untreated eye orbital fat. As you can see here, the cell density increased in the treated eyes. Adipocyte density increased in bimatoprost and toroprost treated eyes, however, not in the latanoprost. Fat volume may decrease by prostaglandin analogs treatment. So next, we studied whether FP receptor can reduce the lipid or not in 3T3L1 cells. 3T3L1 cells is adipocytes. After differentiation, these cells indicates the fat. The red stained area showed lipid droplet. As you can see here, 4 kinds of prostaglandins, latanoprost, toroprost, tafloprost, and bimatoprost acid, and also FP agonist PGF-alpha completely inhibit the production of lipid in these cells. So this is a graph of that histological analysis. So lipid volume of prostaglandin treated 3T3L1 cells by counting of oil area. In the presence of 4 kinds of prostaglandin analogs and PGF-alpha, lipid production was significantly suppressed. So these basic data suggest in PAPS, so probably lipid volume reduced by prostaglandin analogs. So I want to show real-world data the frequency of PAPS was different among 4 prostaglandin analogs. So these are typical ways of PAPS. FP agonist-induced PAPS impacts quality of life and quality of vision. PAP is not favorable for many patients, leading to poor adherence. And these eyelid changes affect accurate IP measurement and poor prognosis of filtration surgeries. However, some of the patients favor this side effect. In these patients, she noticed dews and increase of eyelashes. However, she likes these changes. Deepening of upper eyelid dews is a common side effect of prostaglandins. This is prominent in Japanese with shallow upper eyelid drugs. We investigated the frequency of dews by prospective analysis. So prospective masked evaluated 6-month study and blindly evaluated by 3 examiners with photos. 4 kinds of prostaglandin analogs was used for this study, and dews occurred in 6 months in all kinds of prostaglandin analogs. However, the frequency was significantly higher in bimatoprost and travoprost compared to the tafluprost and latonprost. The degree of deepening is quite variable among the patients. And this is a subjective notice of dews by patients themselves. Especially in bimatoprost used patients, they noticed dews compared to the travoprost and tafluprost, latonprost. The patients doesn't notice the dews. The impression also depends on each patient. Another paper indicates the severity of PAPS was different among 3 prostaglandin analogs. In bimatoprost and travoprost, the PAPS was severe compared to the latonprost. So how to address PAPS? The option 1 is switching FP agonist to another one. So this is the Japanese case with dews using latonprost and bimatoprost. So this is a baseline cosmetic changes. So this patient used latonprost for 3 years. So after that, we change latonprost to bimatoprost. So after that, in 3 or 6 months, the dews occurred obviously, and she noticed dews. We switched back to latonprost from bimatoprost. So as you can see here, the dews recovered immediately after switching to latonprost. However, she likes these cosmetic changes. So this is another case. She also used latonprost and switching to bimatoprost. Dews occurred in 3 months, and in 6 months, the dews become severe compared to the baseline. So I changed bimatoprost to latonprost. In 2 months and 4 months, still some dews is present. She's still concerned her dews at this point. So this is our study, switching back from bimatoprost to latonprost. The subjects are 13 OH patients with dews by bimatoprost 6 months use. Objectively, the dews disappeared in 2 months, 85%, and in 6 months, also 85%. Subjective notice of dews in 69% of patients So noticed dues recovered by switching to Ratanprost from Vimatprost. So this switching study, dues recovered up to 2 months and sustained thereafter. 2 cases still present dues at 6 months. However, almost the cases are subjectively satisfied. The second option is discontinuation of prostaglandins by surgery or other interventions. So in this patient, she received filtration surgery in the left eye after 3 months. So as you can see here, PAPS improved. However, she still complains this swelling. Improvement of PAP by surgery is not always good things for patients. So after that, I did the filtration surgery to the right eye, and finally she is satisfied. So these are another cases. These are the other cases. So this patient received trabeculectomy in the right eye, and after 6 months, so these changes recovered. Also, this patient received filtration surgery in the left eye. After 6 months, the dues improved. However, these patients complain these appearance more than before surgery because there was a difference of the cosmetic changes. The third option of addressing PAPS is replacement of prostaglandins to APGS agonist Omidinepag. Omidinepag isopropyl is a new APGS agonist we called Adherence. So this is one drop once daily. This is a novel anti-glaucoma drug first approved in Japan, Korea, and Taiwan. Omidinepag is a selective APGS agonist without prostaglandin skeletons. So as you can see here, this structure doesn't include the prostaglandin structure. So this means Omidinepag doesn't bind to FP receptor and binds only to EP2 receptor. Omidinepag EP2 agonist demonstrated non-inferior IOP lowering effect compared to Ratanprost. So this is an important study. So Omidinepag is the first drug since Ratanprost launched, so around 20 years ago. The IOP reduction is comparable to Ratanprost. EP2 agonist Omidinepag showed no effect on the eyelashes and hair cycle in the mouse. So this is a mouse study. There was no change of hairs and also no effect to hair cycle. Also, EP2 agonist Omidinepag doesn't have the effect on the monkey iris color and eyelid zulux changes. So this figure indicates there was no change of colors even after 39 weeks treatment with Omidinepag. And also there was no dues occurred in these monkeys. This is an in vitro study. So EP2 agonist Omidinepag doesn't inhibit the adipogenesis in the 3T3L1 cells. So this is a control negative study with Ratanprost acid and prostaglandin F2 alpha. So these FP agonists inhibit the adipogenesis. However, even the high dose of Omidinepag doesn't affect the production of lipid. So these data suggest PAPS may not occur by APGS agonist Omidinepag. So I want to show some real-world experience. We followed the patient used Omidinepag after switching from FP agonist. We observed cosmetic effect of Omidinepag. The subjects are 19 glaucoma patients. So after changes to omidinipal from FP agonist, the dose improved 58% of the patients in 1 month and 68% patients in 3 months. So during these periods, there was no change of IOP. So this means omidinipal can improve the dose, so without changing IOP. This is one of the case of the patient with dose by FP agonist. After switching to omidinipal 1 month and 3 months, so as you can see here, dose completely recovered compared to the baseline when she used FP agonist. Omidinipal treatment has a benefit to recover PAPS after switching from FP agonist without changing IOP. So omidinipal can reduce IOP similar to latanoprost. And also, Everest omidinipal can improve the cosmetic side effect of prostaglandins. So I recommend to use Everest omidinipal for the patient suffering from cosmetic side effect. So this is a summary. So how to address DUEs? PAPS, including DUEs, is a reversible side effect by prostaglandins. Frequency was high in order of imatoprost, travoprost, tafluprost, and latanoprost. And in cases who complain use or whom clinician concern, the first option is switching FP agonist to tafluprost or latanoprost can reduce PAPS. The second option is discontinuing FP agonist can improve PAPS in a few months. The third option is switching FP agonist to EPZ agonist, so without changing IOP reduction. Thank you very much.
Hold me down. Hold me down.
Okay, I would like to give many thanks to all our presenters for the second session. Now this time is open for our Q&A. If the audience has any questions, please feel free to submit your questions to the chatting window. In the meantime, I'll go ahead with some of the questions that were brought up by the audience to our presenters. The first question is there any side effect in the treatment with prostaglandin analogs in glaucoma patients with thyroid orbitopathy? Now, I hope this question relates to the side effects of prostaglandin analogs with patients with thyroid orbitopathy. Professor Aihara, do you have any thoughts on this question?
Yes. So actually, I didn't try this for the patient with thyroid orbitopathy, but my colleague, one of my colleagues tried to use bimatoprost for the glaucoma patient with thyroid orbitopathy. But as a result, there was no special side effect for the thyroid orbitopathy. So he may expect some PAP may not happen for these thyroid orbitopathy patient, but in his experience, there was no special side effect for them. So
what was his rationale? What was his rationale for expecting any side effects using the prostaglandin analogs in thyroid orbitopathy? Makoto?
Yes. So one of the side effects may enhance the
inflammation.
The inflammation, yes. And another point is bimatoprost or prostaglandin analogs may reduce the production of the lipid.
I see.
But there was no change. So
in terms of inflammation and also the loss of fat tissue in those patients with thyroid orbitopathy. So it's safe to use PGA drops on thyroid orbitopathy patients. But still, would you recommend using OMD instead of PGA because it's a less, is there any difference in terms of inflammatory response between the two compounds?
So maybe no, but his experience, I've never tried that.
Thank you. Another question here is, after switching from latanoprost to bimatoprost, did hypotensive effect persist? I guess this question is fairly obvious. In some patients, I can answer these questions because Professor Sung already covered this. Bimatoprost is known to be slightly superior to latanoprost in some studies in terms of IOP reduction. But of course, depending on studies, both compounds result in similar pressure reduction. So certainly, I think you can expect that even after you switching from bimatoprost to latanoprost, you can expect similar hypotensive effect with the latanoprost. May I ask this question to, I guess, Professor Aihara, because you're the one who has used this compound the most. Is EP2 receptor agonist, OMD, is it available in India? This is something that you may know because the company is located in Japan.
Yes. So unfortunately, in India, it's not allowed. But maybe someday we'll do that in future. So now in Japan, Korea, and Taiwan, and maybe soon Singapore. That's all.
Okay. I can ask this question to Professor Kessara. You talked about the importance of adherence during your lecture, and you talked about some alternative way to improve the adherence among glaucoma patients, because we all know that the adherence is a big issue in glaucoma patients. And as an alternative, the use of laser, such as SLT, or even the use of minimally invasive glaucoma surgery can actually replace or can improve the adherence in poor adherence in glaucoma patients. And what are your thoughts on this, Professor Kessara? And do you ever think about using SLT or even mix in patients who show poor adherence with the medication?
Thank you, Professor Cook, for bringing up this point. This is a very interesting question. As I mentioned in my lecture, that some of these measurements, like intervention, glaucoma, early intervention, it might help in some patients, but it depends also on the type of which glaucoma that you have. If you have like a very advanced glaucoma, I would say that for the SLT might not help a lot. But if you have an early glaucoma, like an early PRAG, it may help in this kind of patient. As well as their mix is difficult to say, because mix, as we already know, that their efficacy, especially in those with the mixed, nearly mixed, not the subconjunctival mix, for the efficacy is not that low, and it may not help to the very advanced glaucoma, and it's quite new. But we may consider that especially in VR, know that they are progressing because of their poor adherence or something like that. The problem is that mix is not available in every country, and there's some kind of mix only, like in Thailand, it's only the subconjunctival mix that available right now. So I think that it will be an option, but it's still cannot replace the medication in some patients.
Professor Sung, do you have any thoughts on this question? You do a lot of mix in your clinical practice? So.
Yeah, recently I started mix for the patients who are had difficulty in using medications. For instance, if the patient is well controlled with the MTMT, but if there is severe side effect, I'm trying to change the use to mix, and then the patient's response is very good because the mix has the complication post-operative side effects is very low compared with the trabeculectomy. But we have to see the long-term result. I'm not sure about the long-term result of mix still. Yeah, I was worried
Thank you.
about it.
Great comments. Yes. So I agree with both of the presenters' comments on the use of SLT or mix on patients who are not adherent to glaucoma medications. Here's another question from the audience. How often do you see PAPS in your practice? I think this probably question goes best to Professor Aihara. You mentioned in your lecture about the prevalence or the prospective Japanese studies, and your personal thoughts on this?
Yes, as I mentioned in the slide, I often see PAPS in the bimatoprost users compared to the latanoprost or tafloprost. So in order of the frequency of PAPS, so bimatoprost, travoprost, and maybe similar latanoprost and tafloprost. So that's the order of the frequency of PAPS. So, of course, the frequency depends on the cosmetic, the shape, the type of the face. So it's very hard to say how often. So the percentage is very variable. Maybe depends on the race or.
Well, here's a question relating to your comments. It's a question by Professor Tara. You reported this PAPS occurring quite frequently in patients who receive 0.03% bimatoprost. But do you have any experience of patients who use 0.01%? Now, you know, there are lesser concentration of bimatoprost available. What's your thoughts on that?
So that's a good question. So unfortunately, in Japan, 0.01% is not available in Japan. So I've never tried, but maybe the company expected if the patient use 0.01, the frequency of PAPS will be less compared to 0.03. So maybe definitely the frequency will decrease compared to 0.03.
I see. Okay. I'd like to direct this question to both Professor Sung and Professor Aihara, because you mentioned about the effect of a DUEs on glaucoma surgery. So if you were to stop PGA prior to glaucoma surgery because of the undesirable outcome related to use of related to DUEs or PAPS, how much time should we wait before we proceed with surgery? Any thoughts? I'm not sure if there's any right answer to this. Professor Sung, do you have any speculation on this?
Thank you. Actually, I think I don't have time to stop using PG analogs before surgery because the patient who underwent surgery is usually very urgent conditions. So we don't have room to stop the medication. I'm continuing using the medication, and after surgery, I stop the medication, and I usually find the eyes which underwent the surgery, their PAPS is fixed, improved, but the other eye remained having PAPS, so that's asymmetric. The shape is appeared. So I'm continuously using the medication. Unfortunately.
Professor Aihara?
Yes, I usually continue the medications, but if we have a time, I can change the the Bimatprost or Travprost to Tafilprost or Latanoprost
Mhm.
if we have a time before the surgery.
Right. Of course, as Dr. Sung mentioned, oftentimes those patients who require surgeries, oftentimes they have high pressures and very advanced glaucoma. So I think it's very difficult to stop any medications in the middle just because they are assumed to have a side effects or assumed to have a bad outcomes on glaucoma surgery. Anyway, I have one last question before we have to wrap up this session here. This question may be best for Professor Kessara. Is there a risk of reduced communication between a doctor and glaucoma patient with introduction of AI into clinical practice? Can this have an impact on patients' adherence?
Yeah,
Professor
this is
Kessara?
yeah, thank you. This is a very good question, and I think it's still in questionable. But in my opinion, that I would say that it might reduce the communication, but I would say that the AI cannot replace the doctors because they have no sympathy. I think the sympathy is the most important of our doctors that we can do to the patient, and we can communicate them, and we can educate them and teach them what is the glaucoma, what is the importance, something like that. I would say that the AI might reduce, but it cannot replace, but it's because they have no sympathy. I would say that, something like that.
Any other comments from the panel? If not, then I have to conclude this second session. And the topics were very interesting, and I really like to thank all the presenters for their excellent talk. And I'd like to hand up the last wrapping comments to Professor Catherine Liu for closing comment. Professor Liu, are you there? I think we are having little technical problem here. So if you can just bear with us, I think that Professor Liu has something very important to say before we conclude this webinar this evening.
Thank you for your reminder. Yes, I think this webinar just reminds us once again the importance of stable and sustained IOP reduction in the preservation of visual function in patients with glaucoma. Both 24-hour IOP fluctuation and the long-term fluctuation matters. Since we treat the patient as a whole, but not just reduce the pressure, so I think local and sustained side effects, direct and indirect cost of treatment, and the patient's quality of life should all be considered. Prostaglandin analog has potent IOP reducing effect, and its daily application is convenient to patients. But the orbital prostaglandin associated orbitopathy syndrome is not just a cosmetic issue. It may have negative impacts on subsequent ocular surgery. It may reduce the success rate of glaucoma filtering surgery and may make it difficult for all kinds of intraocular surgery, because when patients lie down, the eyeball may sit below the orbital rim and make it difficult to approach. And this is even more difficult if it is associated with ptosis and tight eyelids. Being a chronic disease, glaucoma, patient adherence is the key to achieve success in the treatment of glaucoma. glaucoma. So the importance of patient education and a good physician-patient relationship could not be overemphasized. Thank you for joining us in this webinar, and thank you for all the speakers for your wonderful and enlightening speeches. Thank you for all online. The 5th Asia Pacific Glaucoma Congress will be held in June. This virtual meeting will bring us the latest in glaucoma development and provides opportunities for Q&A, for live Q&A with our speakers and delegates. So if you have not yet registered, I encourage you to do so as soon as possible. And thank you again for all of you. Thank you, Michael. Goodbye, and I wish each one of you a wonderful weekend. Bye-bye.
Professor Chu, thank you. Professor Lu, thank you very much.
Thank you very
Thank
much.
you.
Please
Thank
stay
you very
safe.
much. Thank you. Bye-bye. Thank you very
Bye-bye.
much.
Thank you very
Thank
much.
you.
Kill this part that stays away.